ठीक, मैं ग्रुप पे अनाउंस कर लेता हूँ 1-2 मिनट, फिर वेट करके हम इंट्रोडक्शन करवाता हूँ।
फोन को कैसे मैं एयरप्लेन मोड पे कर देती हूँ, कॉल्स नहीं है।
बिस्मिल्लाहिर्रहमानिर्रहीम, अल्हम्दुलिल्लाहि रब्बिल आलमीन, अस्सलातु वस्सलाम अलैका रसूलुल्लाह। तो मैं सबसे पहले आप सबको वेलकम करना चाहूँगा हमारी क्लिनिकल वेबिनार सीरीज़ में। पहले हमारे 3 फ्री क्लिनिकल वेबिनार हो चुके हैं और हमारा जो पिछला वेबिनार था दैट वाज हमारा आखिरी वाला वेबिनार और वो हमने ख़त्म कर दिया। और वो कहते हैं एक चीज़ ख़त्म होती है तो शुरुआत होती है और अच्छी चीज़ की। तो अब हमने जो सीरीज़ शुरू की है वो है हमारी गेस्ट स्पीकर सीरीज़ और हमारे जो पहले वर्थी चीफ गेस्ट हैं नन अदर देन आप सब जानते हैं, कोई तारुफ की मोहताज नहीं है, डॉक्टर नजिया इलियास। उनका तारुफ करने के लिए मैंने एक छोटी सी आपके सामने एक स्टोरी कोट करना चाहूँगा, 2 लाइन, बहुत शॉर्ट में, ज़्यादा वक्त नहीं लेना चाह रहा। कि एक बहुत बड़ा लेक्चरार था, वो स्टेज में तकरीर कर रहा था, उसके सामने बहुत सारी किताबें पड़ी हुई थी लाइन में 1 2 3 4 5। एक आदमी आया उधर स्टेज में और उसने किताबों की तरफ इशारा करते हुए कहा ये क्या है। तो वो बड़ा लेक्चरार था, उसके सामने स्टूडेंट्स थे, उसकी उसकी हट गई, उसको गुस्सा आ गया, उसने कहा कि गुस्से से कहा कॉलर ऊपर करके, ये वो है जो तुम नहीं जानते। तो उसने, जो बंदा आया था, उसने एक किताबों को हाथ लगाया, सामने पानी का तालाब था, सारे किताब गिरे। वो जो लेक्चरार था वो और गुस्से में आया, उसने किताबों को वापस उठाया और हैरानगी की बात ये हुई कि एक भी किताब में पानी नहीं लगा। अब जो लेक्चरार, जो अपने आप को बड़ा समझ रहा था कि बड़ा एफसीपीएस क्वालिफाइड बंदा हूँ, एमडीएस वाला बंदा हूँ, वो हैरान हो गया। उसने बोला पानी कैसे नहीं आया। अब उसने सवाल किया ये क्या है। तो और अब उसने जवाब दिया मुस्कुराते हुए, ये वो है जो तुम नहीं जानते। तो एग्जैक्टली मैं आज की ये जो सिचुएशन डाल सकता हूँ कि मेरे लिए डॉक्टर, और फिर उसने, जो लेक्चरार था, उसने चीख मारी और उसने फौरन कहा कि यार ये मैं, आप मुझे अपना मेंटोर बना दें, मैं आपको उसी वक्त उसके साथ चला गया। तो एग्जैक्टली यही सिचुएशन है। तो हम लोग इंस्पायर हो जाते हैं काफ़ी, कोई प्रोफेसर हो, कोई एचओडी हो, कोई डीन हो, वाह भाई ज़बरदस्त। लेकिन असल जो इंस्पिरेशन हमें हासिल करनी चाहिए वो हमारी क्लिनिशियंस हैं जो बहुत अच्छा काम कर रहे हैं। उनका, मैं डॉक्टर नजिया को नहीं पता, मैं उनको काफ़ी टाइम से फॉलो कर रहा हूँ फेसबुक पे, उनके मैंने केसेस देखे हुए हैं। और मैं जब ट्रेनी था, और वो अभी भी, अब वो फर्स्ट टाइम खुद अभी सुन रही हैं ये बात, तो मैं तब से फॉलो कर रहा हूँ उनका बहुत। आप भी उनको फॉलो कीजिएगा, उनका क्लिनिकल वर्क बेंचमार्क है। और हमारी खुशनसीबी है कि वो हमारे साथ मौजूद है। उन्होंने बहुत सारे डिग्रीज वगैरह की हैं, वो मुझे पढ़ने की ज़रूरत नहीं, वो आप लोग ब्रोशर्स में पढ़ सकते हो। मैं वो बात बताना चाह रहा हूँ जो आप लोगों के सामने रखना चाह रहा हूँ, जो कि ज़्यादा इंस्पिरेशनल बात है। मजीद वक्त नहीं लूँगा, आप लोगों को मैं वेलकम करना चाहूँगा, डॉक्टर सादिया, मुजीब, डॉक्टर साजिद, फजीला, नौफल, नदीम। और अब डॉक्टर नजिया, थैंक यू सो मच। अब आप प्लीज़ कैरी ऑन विथ योर प्रेजेंटेशन।
अस्सलाम वालेकुम जाज़े, बहुत शुक्रिया। और इस इंट्रोडक्शन का इस काबिल तो नहीं हूँ मैं, थोड़ा सा बस मेहनत की है और कुछ भी नहीं। अब अल्लाह अगर उस मेहनत का सिला लोगों को इंस्पायर करने की सूरत में दे दे तो बहुत जज़ाकल्लाह। आपका भी और अल्लाह का शुक्र अदा करते हैं कि कुछ थोड़ा सा कंट्रीब्यूशन करने के लायक हो गए हैं। इंटायरली तो नहीं, बिकॉज आई एम नॉट दैट क्वालिफाइड, मुझसे ज़्यादा पढ़े लिखे लोग मौजूद हैं, आप लोग हैं। बट ये है कि कुछ चीज़ें मैंने अपने एक्सपीरियंसेस से सीखी हैं बिसाइड्स लर्निंग। और एक चीज़ जो मुझे सबसे ज़्यादा समझ आई इतने सालों की मेहनत के बाद, बिकॉज मैं तकरीबन 17 एक साल हो गए होंगे मुझे ग्रेजुएट किए हुए, और मेरा क्लिनिकल एक्सपीरियंस अगर देखा जाए तो वो 8-9 साल से ज़्यादा का नहीं है, क्योंकि मैंने काफ़ी ब्रेक ले लेके काम किया। बट एट द एंड ऑफ द डे जो मुझे लगता है कि एक क्लिनिशियन जितना बेहतर चीज़ों को परख सकता है, वो शायद एक टीचर नहीं उसको गैदर कर सकता, नो मैटर वो कितना लर्नेड हो। तो आई जस्ट ट्राई टू मेक ब्रिज बिटवीन दोज। एंड आपके इस जो आपने कहा गेस्ट स्पीकर, आई डोंट कॉल माई सेल्फ एज अ गेस्ट स्पीकर, आई वुड रादर से कि मैं एक नॉलेज पास ऑन करना चाहती हूँ जो मुझे मेरे मेंटोर्स ने पास ऑन किया, एंड दे हैव आस्क्ड मी टू पास इट ऑन फर्दर। तो ये मेरा उनके लिए एक तोहफा है कि मैं उस नॉलेज को आगे शेयर करूँ। सेकेंडली, ये जो लेक्चर है, इट्स स्टोरी ऑफ नॉट माई सक्सेसफुल केसेस, but it's about my failures, which I have actually learned over a period of time after thorough analyzing my cases. And there had been two major contributing factor to those, which were photography and following up my cases. So ये मेरे बहुत बड़े teachers रहे हैं, like documentation and following up. So I would be sharing um, my blacklist of my restorative failures, so that you can learn and you could avoid doing the same mistakes which I did. And you don't end up wasting your time, energy, and finances over your failed cases. You rather learn from it. प्रेजेंटेशन में अपनी स्टार्ट करती हूँ। दिस इज़ द ब्लैक लिस्ट ऑफ माई रेस्टोरेटिव फेलियर। थोड़ा सा मेरा इन्फो है, not much, but I have been a part of continuing education courses for past 8-9 years. And the day I started, it's a never ending process, it's an addiction. I graduated from Bakai Medical University, it's my alma mater, in 2005. And due to having kids and married life, I could not continue my work. But after few years of graduation, I joined JMDC as a demonstrator for 2 years, and I learned a great deal from there. Recently, I did my fellowship in TMD, orofacial pain and sleep medicine. And this is me, and I work in a welfare private clinic in a madrasa in Karachi. It's a very renowned madrasa. And I've been working ever since, like for past 9 years, and I've been trying to give and contribute to those to the needs of those deprived students, female students, and staff who have no access to good quality dentistry. मेरे कुछ इंस्पिरेशंस जो फोरम है, इट्स राइप ग्लोबल, रीवर्स इन डेंटिस्ट्री, एंड AOA and Tomorrow Tooth. The reason I want to share these names is, for past 6-7 years, RIPE has served as a teacher. जो मैंने केसेस से राइप ग्लोबल पे या टुमारो टुथ पे देख कर सीखा है, वो शायद मुझे कोई हाथ पकड़ के भी नहीं सिखा सका. And I really encourage all of you to join those forums and watch how like look at those full protocol cases and how the things are done. So it will really help you in improving your work. There is a small difference in doing and not doing. If you think आप नहीं कर सकते, you cannot do it, you can never do it. So it has to be your passion of doing things the right way, instead of blaming the circumstances, the lack of equipment, lack of resources, and not having access to good quality education. I would never blame those. I would rather blame myself for not taking first step. So I suggest that you all start the can do thing in your life instead of saying I can't do it. Let's start with the blacklist of my restorative failures. This is a complete list which I have made after thoroughly analyzing my cases, and I would start it with the diet. A patient presents to you and says that I have got cavities and black stains on my teeth, and what I would first look at is what diet is he up to or is she up to. If it's acidic diet, refined carbohydrates this patient takes, frizzy drinks, citrus juices and fruits, I would see such a scenario जैसे कि इस patient में हुआ. And if I do not address the basic cause, my doing such fillings would end up into this. This is my case done couple of years back, and I did restore these teeth. This patient followed up, and I saw these areas of discoloration. My whole work was ruined. Literally, I spent hours, and she came up with more decay. So, was choosing the composite a right decision in such a case where I could not address the diet? No, it was a failure. Same goes here. This patient came and she had limited resources, and I could not give crowns. So I ended up doing composites. And after a few years, she came back with more lesions and with more discoloration because I could not address her diet. So it's imperative that before going for any kind of restorative work, you make sure that you at least manage the dietary plan of the patient. Another case, she had the same issue. She was on refined carbs, taking lots of chocolates and sweets, and I did some patchwork here. But after a couple of years, she came back with more lesions and recurrent decay. So it was a failure on my part. This study says that where of resin composites, current insights and of into underlying mechanism, evaluation methods, influence factor. In a nutshell, if you know that plaque acids, food constituents, and enzymes have been shown to soften and roughen resin composites. The thing is, अगर आप उन acidic diet और उस food को address नहीं करेंगे तो it ultimately softens and roughens the resin composite and would cause recurrent decay in anteriors, possible discoloration, even chipping and breaking of composites. So it's better to look at diet. This is a small table showing what is the pH of different food beverages we take. And if you see clearly, the Red Bull that people frequently use, its pH is 3.4, and grapefruit juices 3.2, red wine like in possibly non-Muslims, red wine is a frequently used. Look at the pH. Vinegar. Some people love using vinegar in their food. Look at the pH. The second list is habits. I need to make sure that my what habits my patient has before doing any restorative work. Is it abstraction, toothbrush wear? I know some people may not agree, but I have seen and witnessed it, and I have clinical follow up of such cases. Parafunctional habits, nocturnal bruxism, tongue thrusting. I would show you a couple of pictures to prove that. Okay, this is my father's case. He is a heavy bruxer, and I did this full mouth composites 4 or 5 years ago, and you would not believe after 3 years he presented to me with this. He has almost worn down all the posteriors. It's not that I did not do good isolation. The anteriors are still holding fine, but his posteriors are they're gone now. All the composite is worn off. So my effort went fruitless. Same case, he also has toothbrush trauma. I would not call it trauma due to occlusal interferences, these class 5 lesions, because I have actually seen him doing that. This is a typical toothbrush trauma. I did the patchwork, I did the class 5 fillings very meticulously with rubber dam, with everything. But after 1 year, look at here, he has developed it back because he has worn them down again with aggressive toothbrushing, and you can see the composite is still holding up with premolars. So it was not the occlusal interference which has caused the class 5 lesion, it was the toothbrush trauma, especially on that side. This study proves it. If you want to have a screenshot of that, you can take it. Another one is facial profile. I always look at what type of facial profile a patient has before I go to any restorative work. Is he long faced, short faced, normal faced? I see and I have noticed that people with brachycephalic profile, that is short face, they have a liver movement arm which causes more forces on the posterior because of the short distance of masseter, and they develop heavy masseters, as you can see in this case. This lady, she is brachycephalic, she's short faced. Look at the tooth pair she has. Would I go ahead and patch up this lateral incisor, tooth number 1, 2, before addressing her cause? No, I would rather go back and address her reason, the cause which has been causing it. I would rather do a Botox or give some night guard or anything which can actually stop, not if even if not stop, minimize her mesenteric activity, because she cannot control it. She has, the profile, she was born with it. So what I can do is, before going for any restorative work, I have to make sure that she does not end up breaking this lateral incisor. Okay, this is the most common ignored factor in restorations, failure. And I name it under interferences, group function, incisal guide table, and pathologic migration. Let's see in this case. Here, this lady, she says she never had diastema and procline teeth. She has developed it over 10, 15 years. And when I saw her occlusal scheme, she had missing molars and she had developed interferences, especially in her upper sevens. So instead of having a contact on all the teeth simultaneously, she had initial point of contacts on the sevens, which resulted in centric slide and shift to anterior teeth, and she ultimately lost the lower central incisor, and she was about to lose her centrals. So, before addressing her occlusal scheme, I could not have restored her anteriors. I would not even think of giving an implant to the missing lower central, or extracting or doing any work in upper centrals to improve her smile. So it took me almost 2 years to establish a better occlusal scheme in order to improve her aesthetics. Same is the case here. This lady on the top left, she came to me with these crowns, saying that these are failing, these are loose, and they also have exposed metal. When I saw the occlusal scheme, she has anterior open bite. So, on lateral excursions, her posterior teeth were touching first instead of canines. So, the most of the force was transmitted to the posterior. So, that's why, because of the Improper occlusal scheme, she has started to warn off her posterior. If you look at the top, at the bottom case, this lady has couple of time filling done in the upper central distal edge, incisal edge, and the reason it was chipped off frequently was her occlusion. You can see there is a cross bite. Before addressing her occlusion and reorganizing it, I would never do a patchwork. So this patchwork failed because whoever did it, he could not see that she was in bad need of better occlusal scheme than this incisal filling. Here's this case I did. This is a this is a broken zirconia crown. The reason was I did not um, make a proper occlusal scheme on that crown, which resulted in the breakage of zirconia. So you cannot say that zirconia lasts forever. It may not, unless you do not know or you do not apply the principles of occlusion here. You can also see there is exposed metal on the porcelain crown as well, and it is because the contact should not have been there. The contact was which was supposed to be in the center and marginal ridge. It's on the inclined plane, which has resulted in patients adjusting to maximum better intercuspation and ultimate wear of the porcelain, exposing metal. Same goes on the top right picture. You can also see the same scenario in the bottom picture, exposed metal, just because there was not a proper occlusal scheme provided on the crowns by the laboratory. This is a failure. Look at this case. This lady came to me with a fractured cusp, functional palatal cusp. And back then I had no clue about occlusion. And I did the patchwork. And believe me, after 2 years, she came back with the same broken cusp because I did not address the occlusion here. I only did the patchwork. I should have known that especially this cusp, was taking the load first, and then she was trying to adjust her bite into a better position. So her first point of contact was on that cusp, and you can also see the wear. So it was an alarming sign which I missed. Ultimately, she broke it again. That was a failure on my part. You can see in this study, and it says that this type of wear has not been shown to contribute significantly to the wear of resin composite, but it may appear at locations where an opposing cusp or contact point is forced against a resin composite surface. That means कि सिर्फ सलाइवा ही नहीं है कि अगर आपका एडहीसिव वेयर हो रहा है या कॉम्पोजिट ब्रेक हो रहा है, इट्स बिकॉज ऑफ अदर फैक्टर्स. इट मे ऑल्सो बी बिकॉज कि आपका कॉन्टैक्ट उधर प्रॉपरली प्लेस नहीं है, and there's this constant force which is actually causing a fracture and stresses in that composite filling. The same goes for restorations, fixed restorations, direct, indirect. If you do not put a proper cusp to fossa to marginal ridge scheme, there would be a failure. Either the restoration will break, either the tooth will break, either the cusp will fracture, or either the tooth will start to move. Fremitus. Magnification. Okay. Those were the thing I talked about. जो हम पेशेंट प्रेजेंट कर रहा होता है उस वक्त we see. But during operative procedure, magnification is the most important thing. If you do not see it, you cannot do it. And these are the points. If I go back, open margin, leaking dam. Even if you're giving rubber dam, you have to make sure that's not leaking. Demineralized enamel, infected dentine. Let me show you my case. See, here I did according to my part, a very perfect isolation. But look, I left the open margin between proximal surface of the tooth and the matrix. So it was a failure. Any overhang I would miss, the patient would come again with a recurrent decay under that overhang. Possibly. Look at here. Demineralized enamel. This picture I took after I took the pictures of all the steps, but once I was done and I zoomed them up, I saw, oh my god, I left demineralized enamel. How is the bond strength going to be there? It's going to be weak. So this is a failure on my part. Look at here. You can see the overhang in this restoration, and I missed it. I only saw it when I zoomed it. Look at here. I again left demineralized enamel. So had I seen it before, magnified the image before doing restoration, I would have corrected it. But it was a failure on my part. Next, isolation. Leaking dam again, uninverted dam, improper clamp selection, punch size and distance. These are the few main important points while doing rubber dam isolation. It's not just that you put a clamp on and put a green or blue or pink or whatever color sheet, latex, non latex, fancy tools or whatever. But if you miss these things, the isolation is useless. Look at here. Here I did not actually address the distance I should have punched. So I'm not able to invert the dam even after 15 minutes of trying. Failure on my part. Look at this picture. Here it's again. The distance between the two teeth, there is inadequate distance between punching. So I could not invert the dam here as well. Failure on my part. There would be a constant leakage. Look at here. Even though I was able to, put a very fancy ring and good matrix and all that. But what's the use? There was my dam was leaking on the other side. I could see the slimy bubbles. So I should have addressed it before. I should have, gone for class 2 cavity. So this is a failure on my part. My isolation was not proper. Look at here. It was an endo case, but my clamp selection was pretty wrong. I was using the fancy plastic soft clamps. I should have used a proper clamp, right? So that there would have been a proper isolation. And in order to compensate that, I ended up, giving a pool of liquid rubber dam. Failure on my part. Cavity preparation. Patient present with post-op sensitivity, lingering pain after you do a very nice filling and all that. And then you see this. This is my patient. I did her filling almost 7 years ago. And 2 years back, she says, I'm still having sensitivity in this area. And I had to cut off my restoration. And when I saw there was this decay, failure on my part. Same goes here. If you see, there is this small restoration on premolar buccal side, but then it was not properly done, and I ended up having more decay. This is a very good example of my cases. See, I'm not always doing some fancy work, I'm also making mistakes. But the reason is documentation helps me analyze my mistakes. This lady, she was a young female. I did her class 2 cavity in the upper first molar and premolar. And back then, I did it with proper rubber dam and everything. But after 3 years, she came with a dislodged filling, and I had to do it again. The reason was, if you see closely on the radiograph on bite wing on the upper left side, there's a small radiolucency. That's because I did not excavate it properly and I left the infected dentine, which resulted in dislodgement of the filling. And you can also see in the lower molar, this is also going. And when I did this filling, if you see, I left a little cavity there, and my composite was not properly seated, bonded. And look at here. In the upper right side, the composite is breaking up. Same is the case with the lower radiograph. After I took this radiograph, I had to go back and clean it and redo it. So it costed me my time, energy, and money. And patient also had to go through the same thing again. Failure on my part. This lady had restoration done somewhere else, and she said she has still sensitivity. I could see there was not a properly blended composite. When I opened it up, I saw this recurrent decay. Whoever did it did not properly excavate the caries. She had developed recurrent decay, probably had left it, or even left some overhang that she developed it, whatever. But instead, and when I actually checked it with the dye detector, I could see. Okay, the protocol. And I believe in actually following the protocol. The mere reason is it actually helps you in, counting your steps and doing each step properly. And if you miss any of the step during any procedure, you may end up having different failed results, like preconditioning, sandblasting, etching, bonding, pre-cementation. We do it all the time. But let me show you. Look at this case. You, me, everyone does it, right? But did you notice something? I am unknowingly etching the lateral incisors as well, which I should not have. These were not supposed to be etched. I should have covered them with Teflon or anything, right? Failure on my part. Unnecessarily etching the enamel on the lateral incisors. Look at here. Again, not properly etching. Look at here. This lady had crown done somewhere else, and when I removed these crown, I saw this. Probably whoever did it did not properly condition, remove the biofilm before cementation, or did not even remove the cavity while doing endo or whatever, and cemented the crowns. But look, this is what end up. This is what she actually ended up with. Decay under the crowns. Look at here. It's my case. And here I unknowingly bonded both the teeth. It was not supposed to be. I did rubber dam isolation and everything. But if you look closely, the composite on the distal side of the molar, on the marginal edge, it's it has stuck with the neighboring tooth. And if I go back, it's the same case. Here, I etched this area, and when I applied the bonding agent, I should have separated or covered the other molar, which actually resulted in bonding between both teeth. Failure on my part. Iatrogenics. We actually do it like all the time, especially enamel stripping while crown prep. Flat contact. Look at here. I did this case 7 years ago, and I was so proud of doing it, good retraction cord and fancy photos and everything. But when I saw this, I'm like, what? I actually stripped off the neighboring tooth while doing a crown prep. I should have covered it with something. I should have used fender mate wedges or anything so that I should not have stripped the next neighboring tooth. Okay, here I could see it. After I cemented the crown, there's this flat contact I created on the second premolar mesial side because of the iatrogenic sided failure on my part. Look at here. I tried to do this filling on the molar, but see, because of the crowding of the premolar, I created a disc. See, iatrogenics. I should have known and covered this tooth using any metal matrix or anything so that I would have avoided the stitch failure. Same here. I did this class 2 filling. It was very well adapted, but while preparing it, I created a flat surface on the second molar, mesial side. It's stripped. Now, what to do? It's gonna create a food impaction. The area is not polished, it's rough, it's gonna get decayed. Failure on my part. Look at here. Again, same mistake. I did the rubber dam, I did the wedging, and I did everything. But look what? In order to prepare the cavity, I ditched the premolar twice. See? Now I have to do the premolar. I have to fill it. Failure on my part. Matrix selection. Distortion, improper matrix selection, improper matrix adaptation. You'll see here. Look at this case. I should not have used this matrix here. I should have known that there is very little contact and I should have used a thinner, smaller matrix here. This is a distorted matrix. Now it's gonna replicate a distorted proximal anatomy at the end after doing the filling. Look here. Here, improper matrix selection. Now I have to tug in Teflon just to, adapt it. Not a good thing. Look here again. Slight distortion and leakage. Even though I was using a very fancy bi-clear ring, I did not use a proper matrix. I ended up having a leakage. You can see the shiny spot between the matrix and the margin. And the matrix is distorted. Just I had to, distort it just to make a contact. I should have used a better matrix instead. Look here. And I always take photographs of my radiographs, and I always take bite wings just to check what I actually ended up doing to the patient. Is it a good filling? Is it a bad filling? Look here, the filling is rough. You can see it in this case. This is the same radiograph of this case. This lady, she trusted me. She's a dentist, and I told her I did a mistake. I use mylar strip just to create a small filling. I thought, why waste a matrix on this tooth? It's a very small filling. I can do it with a mylar strip, and look what happened on the radiograph. Failure on my part. I had to redo it again, free of cost, obviously. Ferrule, inadequate ferrule. Look here. This case I did 7 years ago. She's my mother in law. And I gave her beautiful zirconia crown, very well adapted and everything. But look what? One day she was chewing in front of me and then it broke off. The whole solid zirconia came off with the core. And when I actually saw the tooth and I actually saw the core, I realized, oh my god, there was not enough ferrule. And what I did ended up having a failed restoration, and now I have to fix it because she did not want an implant. Just because I ignored the ferrule, I ended up doing a more costly work, a more costly restoration. Failure on my part. Same here. I wish I could have shown you the prep on this case. It was a beautiful prep. You can go check this case on Ripe Global. It's there, and everybody was like, it's a very beautiful prep. And one day this came because the crown came off. Inadequate ferrule. Cavity design. Partial cuspal coverage or full cuspal coverage. We are told to be minimally invasive and remove less structure. This is the latest trend, being minimally invasive. But do we realize that in order to be minimally invasive, we also forget what actually principle of occlusions are applied here? Does this tooth need a partial cuspal coverage or a a full cuspal coverage, be it direct or indirect? Look at here. This tooth had this much big filling. I temporarily fixed it with GIC and then I had to go back and do it. But if you look closely, The lingual cusp is very thin. I should have done a proper partial cuspal coverage restoration, be it in composite or whatever, indirect. But this is not a proper restoration. It should have been covered instead of just a patchwork. Look at here. Very thin buccal cusp. I should have reduced it and then have done and covered the cusp with a better restoration, be it composite or any indirect material. But just, bonding to the thinner cusp, it would result in breaking of the cusp eventually. Failure on my part. Here. I was so proud of, posting this case on a forum like Global. But later on I realized this patient had these many decays and they actually did not need a patchwork. They needed a full cuspal coverage restoration. Look at how much damage the tooth is. They are not gonna live long. And they actually ended up, you know, being decayed and broken again. Look at here. Same scenario. See, unfinished margins, demineralized enamel. Now this adjacent tooth proximal profile. We often ignore this thing, especially doing crowns. Concave proximal box. You see, look, in this case, I did this restoration 7 years ago, and to me it was like perfect. But then one day, this patient came to me with a broken restoration, and then I realized, oh my god, when I did this crown, I should have known that this concave proximal box is creating a food impaction here, and she would ultimately develop a decay, and she actually did. So I had to do a crown here because this tooth was being compromised. It has distal filling, it has occlusal filling, it has mesial filling. Mesial one broke off, and then I had to give a crown. You can also see the wear facet. I should have done a cuspal coverage restoration and I should have altered the proximal profile of the crown. It should not have been concave, it should have been convex, so that there's a proper cleansing contact, a blended contact. Failure on my part. Look at here. Again, wrong proximal profile. God did not create such profile. We created. And then we end up blaming our lab, inadequate crown, you're not doing a good work. We are not actually looking at what type of work we are doing. Look at here. I did deliver the crown, but see, not a proper contact. Even though it's very fitted, very well established, tight, but she ended up having food impaction. She could not floss properly because profile was not adequate. Aesthetics. We do veneers and anterior composites, but do we actually look at these factors? I did not. I'm not sure about you. Look at here. Do you think this is a proper finish? No. I had to do it in the next appointment. Like she came to me, this is being discolored. So I had to spend extra 30 minutes just to polish. Waste of my time, waste of my energy, waste of patient's time, waste of my finances just because I did not polish it properly. Look at here. I did not this case, but whoever did it did not know that whatever filling you are gonna do, it's gonna not work here. Just because there is not a proper shape of the tooth. You need to alter the shape just to blend the composite here. So it got dislodged, broken off. This case, I'm not very proud of, but I have to share it. I did it. It was like initial days of my practice, and this was a young girl, and I had to do two crowns, but there was this lack of communication between me and my lab, and I ended up delivering her these two crowns. I'm not very proud of this case because this is not the shape she actually came for. She came for better work, and I did not give. The shape is not proper compared to the rest of the teeth. Look at this tooth. I had to redo the lower tooth in the lower picture, the central incisor, because the color was not proper. I could not give her crown back then, but then again, I did not even give her a proper restoration. It was a dark tooth. And instead of giving a proper crown or even a properly um, shaded composite, I ended up giving a flat looking composite. This case. I always wanted to post it, but then I was, shy not to post my failures. But here I am telling you. Here, I did not do proper layering. I should have, selected a proper dentine thickness and then a proper enamel thickness and mask this fracture line. But see, it I could not. It stayed there and still haunts me. Failure on my part. Look at here. This case I did 9 years ago. It was my in my initial days. I did not know about how to properly layer the tooth, which composites to use, universal or dentine shade and enamel shade. I just did whatever A1 A2 universal shade composite I had, and this patchwork not very pleasant looking. Not even with the shape or the shade. Look at here, those crowns. This no, these are not the crowns. Yes, these are the restorations. Not very pleasing. I did not actually use the proper tints. Either I should have done properly, you know, shade selected crowns here, or at least done nothing. Should have referred him to a better person. This case, um, this here, she had diastema, and though I told the patient, it's better to close this diastema with orthodontics instead of doing composites, but she insisted. Although patient is satisfied, but I'm not, because these are just square looking crowns. Anteriors, this is not how anterior incisors should look like. Even though this is still going on, but I would call it failure with regards to aesthetics. It's not a very nice looking, teeth. Impressions. We ask our technicians and assistants to pour impression for us and do this and do that. But do we actually analyze what's actually wrong there? Faulty impressions from our side, moisture control. Were we able to actually dry out the tooth before using silicone impressions? Improper mixing, inadequate retraction. Look at here. Such a bad looking impression. I did it. Look at here. Bubbles. If I would send this impression to the lab, and lab would somehow make a restoration, and then it would dislodge or, you know, not fit properly. Look at the undercut I created. Not a very nice crown prep. Bubbles. And then I would start blaming my lab. You did that. It's not the lab fault. It's my fault. I should have done it properly. Cast, powder water ratio, pouring time, voids, cast marking, dye spacing. Do we actually look at those factors? I don't think so. Look at here. My lab sent me this case and I could see it. The cast did not have a proper marking of the gingival tissue. They did not actually mark where the margin is. Either I should have poured it myself, marked it myself, and then sent to lab. And if I'm relying on the lab and receiving such kind of restoration, I should actually take a picture and zoom it and see it. Everybody has mobiles. You can do it and see where the problem is. The crown is not seated on the proper in on the margin. Look at here. I received this case from the lab. See, I sent this impression to my lab, and when they poured it, you can see just where the crown was prepped, there's a big air bubble. It was a faulty impression, and they poured it, and they sent me this picture. Look at, ma'am, look what you did. Failure on my part. And the last, after all the list, after you do all the nice work and rubber dam isolation, excellent composite, excellent polishing systems, doing everything on your part, but at the end not taking radiograph of what you do. Look at here. I always take bite wing radiographs. And see this. My crown is not properly seated. This is how I communicate with my laboratory. And I always take metal trials and I take bite wings just to show where is the error. Either my margin was not proper or not properly um, taken on impression. That's why lab created such a case where there is open margin. Look at here. Maybe failure on my part that I was not able to capture a good impression, and then lab had to make it like this. Here, big overhang. It was a metal trial. See, even the post-in work is not done. I had to share it to the lab. See what's wrong. If you don't do it, how would you see it? If you do not take right wings, you will end up having overhang restoration. Look at here. See? And look at on the top. Whoever did this created overhang. It's not properly seated. So if you do not take bite wing radiographs of your ended work, be it class 2 restorations or very fancy looking zirconia Emax crowns or PFMs, and you end up doing this to your patient, this is going to fail eventually. Look at here. Open margin, open margin. This is going to fail if I would cement this. So, success is not final, failure is not fatal. It is the courage to continue that counts. And I'm still working on that. I'm still working, I'm still analyzing, I'm still documenting my cases just to see where I lack and where I can improve. So I suggest all of you to start taking pictures of your work, of the steps you do. It will not take much time, just 5 minutes out of the whole procedures. You have mobile phones, fancy looking mobile phones. Even people have DSLR cameras. Just take out little time, cover up your phones and take pictures of your work. Unless you do not see it, you will not analyze what mistakes you have done. Thank you so much for listening to my lecture. It was not a lecture, it was just sharing my experiences with you. And I hope that they will help you in your future and you will not do the same mistakes which I did. Thank you, Jazib.
Thank you so much, Dr. Najiya Ilyas. What a wonderful session, और I had also a lot to learn from this. और अगर किसी को आप सबसे ये रिक्वेस्ट है, अगर कोई भी सवाल हो तो प्लीज़ पूछ लें, तो डॉक्टर नजिया मौजूद है हमारे साथ, जवाब दे देंगी। और मैं यही कहना चाहूँगा इन द एंड कि ये जितने भी ब्लैक लिस्ट उन्होंने बताएं तो प्लीज़ काइंडली नोट कर दें अपने पैड में, और जब भी क्लिनिकल काम करें तो
Jazib, I
इन
cannot
चीज़ों का
hear
ख्याल
you.
करें।
जी.
अगर किसी को कोई क्वेरी है, कोई सवाल है तो प्लीज़ पूछ लें, और अदरवाइज बाद में भी ग्रुप से पूछ सकते हैं। डॉक्टर नजिया भी हमारे पास ग्रुप, तीनों ग्रुप्स में ऐड हैं, और उनसे आप राब्ता भी कर सकते हैं आप लोग।
कोई क्वेश्चंस हैं तो मुझसे ज़रूर पूछ लें, कोई टेक्स्ट में क्वेश्चंस हैं यू कैन शेयर, आई कैन आंसर देम।
जी, डॉक्टर नौफल ने सवाल किया है, व्हाट आर गुड लर्निंग सोर्सेज फॉर ऑक्लूजन?
वेल, मैंने ऑक्लूजन जिस बंदे से सीखी, स्टिल माय मेंटोर and I owe a lot to him. I think you should join Ripe Global community. I'm a part of Ripe Global and I'm one of their moderator, and it took me 7 years of struggle posting my cases and eventually being recognized as one of the moderators. It's not a very high profile status, but still, being recognized over there. And you will learn a lot on that group and on their website. Go to the Ripe Global website, and if they have a very subsidized rates for Pakistan and third world countries, not much, hardly, you can say 2500 per month, and you will get to watch so much कि आप हैरान रह जाएंगे. And I started my journey of occlusion with that Dr. Michael Melkers, and जो lecture मैंने उनका स्वीडन में जाकर लिया था, the same lecture is available there, so you can watch it and start learning occlusion. It's very helpful.
ठीक है मैम, दूसरा सवाल डॉक्टर फजीला जमाल का है कि व्हाट इज आइडियल ट्रीटमेंट फॉर ब्रुक्सिज्म।
ब्रक्सिज्म का कोई ट्रीटमेंट नहीं है, टू बी वेरी ऑनेस्ट। ब्रक्सिज्म की इटियोलॉजी को एड्रेस करने की ज़रूरत है, बिकॉज ब्रक्सिज्म भी दो तरह का होता है। वन इज नॉक्टर्नल और एक होता है डे टाइम वेयर। यू कैन नेवर स्टॉप इट, इट्स इन योर ब्रेन एक्चुअली। तो डे टाइम पैरा फंक्शन है, उसके लिए देर आर सम एक्सरसाइजेस। Splints, they don't work much, maybe for some time, but not much. तो स्प्लिंट सिर्फ दांतों को प्रोटेक्ट करते हैं, they cannot treat. There are drugs which actually are helpful in bruxism, but that's a very vast field. You have to learn sleep medicine in order to treat bruxism, especially the nocturnal bruxism. आप किसी को 4 हफ्ते के लिए या 4 महीने के लिए स्प्रिंट दे भी देंगे, the habit will not stop. That person is eventually going to grind the sprint as well. तो आपको उसका स्लीप टेस्ट कराने की ज़रूरत है, एनालिसिस कराने की ज़रूरत है, what actually causing it, because this is a motor disorder, bruxism. It's not a tooth related disorder, it's a neurologic disorder. तो इसको आप न्यूरोलॉजी के पॉइंट ऑफ व्यू से ही ट्रीट कर सकते हैं। स्प्लिंट्स, दे हैव वेरी लिमिटेड रोल।
ठीक है, थैंक यू सो मच। डॉक्टर सोहेब चीमा का सवाल है कि व्हाट सैंड ब्लास्टिंग टेक्निक मटेरियल डू यू यूज।
Well, I don't have the sandblaster yet, but there's this very nice technique which I learned. Start using cavity conditioners, यानी आप जब भी फिलिंग करने जा रहे हैं, always scale and polish the tooth. भले वो पेशेंट स्केलिंग करवाए नहीं करवाए, you have to remove the biofilm. And if you do not have a sandblaster, I would still suggest, invest in a good sandblaster. But if not, get a cheaper one, use aluminum oxide. The best one is aluminum trioxide. But आपको अगर aluminum oxide भी मिल जाता है, dioxide भी मिल जाता है, it will still work. It actually removes the biofilm. और अगर नहीं है आपके पास, तो start using conditioners. They are available. और अगर कंडीशनर भी नहीं मिल रहा है, use acrylic polyacrylic acid of GIC. It's liquid. It liquids actually removes the biofilm from the tooth. Just a single drop before you actually start etching. So scale, polish, and condition the tooth before you etch. You have to remove the biofilm. एक और तरीका ये है कि you can use plaque indicator, dyes. आप scale polish करें, dye लगाएं, and disclose the film. If it's visible, that means कि आपने उसको properly remove ही नहीं किया. How is the restoration going to bond? Then use the conditioner vigorously and apply the dye again, and you will see there is no biofilm.
डॉक्टर रफ़ीउल्लाह खान का सवाल है, और मैं इसको $1,000,000 सवाल रेट करूंगा, क्योंकि पूछ रहे हैं कि योर एडवाइस फॉर न्यू डेंटल ग्रेजुएट्स, क्योंकि आजकल वो बहुत ज़्यादा परेशानियों में होते हैं, तो प्लीज़ काइंडली उनको एक मोटिवेशनल एडवाइस दे दें।
देखिए, मैं इतना कहूँगी कि मुझे आज अगर आपसे बात करना नसीब हो रहा है, तो इट टुक मी हाउ मेनी इयर्स। मैं 2005 की ग्रेजुएट हूँ, ठीक है, एंड आई हैड ओनली 10 years of clinical practice. So it's never too late. you know Try to be patient with your circumstances and never lose hope. I see people start losing hope so early. Job नहीं मिल रही है, attachment नहीं मिल रही है, काम नहीं करना है। आपको काम करना है, आपको काम सीखना है। आप किसी के सर पे खड़े होकर सिर्फ उसको ऑब्जर्व करना शुरू कर दें। एंड आई एक्चुअली डिड दैट। आई यूज्ड टू टेक माय किड्स टू अ डेंटिस्ट। शी इज अ एक्सीलेंट पर्सन। और जब मेरे बच्चों का काम हो रहा होता था, आई वुड जस्ट आस्क करके, मैम आपको मैं थोड़ी देर सिर्फ ऑब्जर्व कर लूँ, एंड आई वुड डू दैट। एंड व्हेन आई एक्चुअली स्टार्टेड माय प्रैक्टिस, आई आस्क्ड हर कि मैं आपको फ्राइडेज में 1 घंटा आके ऑब्जर्व कर लूँ, इवन दो मेरी प्राइवेट प्रैक्टिस अच्छी चल रही थी। तो अगर आपको पेड अटैचमेंट्स नहीं भी मिलती हैं, यू वुड नॉट बी लूजिंग एनीथिंग। जस्ट गो टू पीपल, आस्क देम, यू वांट टू ऑब्जर्व। दिस वे यू वुड बी लर्निंग अ लॉट। इट्स नॉट जस्ट कि हर दफ़ा पैसे कमा के ही लर्न किया जाता है, बगैर पैसे कमाए भी लर्न किया जाता है। एंड प्लीज़ स्टे होपफुल, बी पेशेंट, योर टाइम विल कम। अल्लाह मियाँ ने हर किसी का टाइम लिखा है और वो उसी वक्त आपको मिलेगा। तो जल्दबाजी से कुछ भी नहीं होता है। दैट्स माई एडवाइस। एंड इन्वेस्ट इन योर लर्निंग। कंटिन्यूइंग एजुकेशन के कोर्सेज, आई नो दे आर प्राइसी, दे आर एक्सपेंसिव, बट दे आर वर्थ इट। अगर आप पहले नहीं सीख सके, कोई बात नहीं, save money, stop saving on your luxuries, spending on your luxuries, start saving and spend on these courses. They will really help you, and they did help me a lot.
थैंक यू सो मच डॉक्टर नजिया, बहुत ही काम की एडवाइस है। और मैं भी यही आगे ऐड करना चाहूँगा कि जितने भी यंगस्टर्स हैं, तो अपनी विजन है वो दो विजन, दो किस्म के मुझे लोग मिलते हैं जो ग्रेजुएट्स होते हैं। मैं पूछता हूँ तुम क्या बनना चाहते हो, कहते हैं यार ये जो एचओडी है ना फला, ये मेरा इंस्पिरेशन है। या किसी बड़े ओहदे वाले को देखते हैं, ये मेरा इंस्पिरेशन है, किसी मुझे प्रोफेसर बनना है। तो आपको जो विजन है ना उसकी करेक्शन करनी पड़ेगी। और योर विजन शुड बी क्लिनिकल ओरिएंटेड। आपको ये कहना पड़ेगा, ये बोलना पड़ेगा कि मुझे बेस्ट क्लिनिशियन बनना है, और ये बनना आसान है। आपको ये भी बोलना पड़ेगा। हम कहते हैं यार ये तो बहुत मुश्किल है, तो व्हाट, जो आज झूठ हम अपने आप से बोलेंगे वो कल हमारा सबसे बड़ा सच होगा। तो आसान है, बट अगेन इट टेक्स टाइम। बट दोनों से मुश्किल है। आसान है क्लिनिशियन बनना, अच्छा बनना, बट इट टेक्स टाइम, टेक्स पेशेंस। जैसे मैम कह रही हैं कि वो इतने साल बाद आके फ्रंट पे आके बात कर रही हैं, तो वो उन्होंने एक स्ट्रगल पीरियड देखा है जो हमें नहीं दिखाई दे रहा। वो होगा, वो डेफिनेटली होगा, वो मेरा भी पीरियड है, वो सबका है। तो एक क्लिनिक, जैसे कहते हैं ना सचिन तेंदुलकर बनो क्रिकेट के, तो मेन वही मैं कहूँगा, डेंटिस्ट्री के क्रिस्टियानो रोनाल्डो बन जाओ, लियोनल मेसी बन जाओ या सचिन बन जाओ, तो तुम्हें क्लिनिशियन बेस्ट बनना है। और इसका स्कोप बहुत ज्यादा है। इसमें कोई ये नहीं कह सकता कि क्लिनिशियन बनने का स्कोप नहीं है, वो झूठ बोल रहा है अपने आप से। क्योंकि हमारे
Exactly.
पास कितने लोग हैं, कितनी पॉपुलेशन है, और एक बंदा मतलब 32 पेशेंट, और हर घर में लोगों को दांतों का मसला है। और मैं कहता हूँ हमारे पास क्लिनिक्स बहुत ज्यादा कम है। वो कहते हैं सर ये कैसे कह रहे हैं, इतनी सारी क्लिनिक्स पड़ी हुई है। मैं कहता हूँ नहीं भाई, दुकानें खुली हुई हैं, क्लिनिक्स नहीं है हमारे पास। तो क्लिनिशियन बनो, दुकानदार ना बनो। क्लिनिक खोलो, दुकान ना खोलो। अब अपने सराउंडिंग में देखो कितनी क्लिनिक्स में रबर डैम इस्तेमाल होता है, कितनी क्लिनिक्स में प्रॉपर रेडियोग्राफी होती है, कितनी क्लिनिक में क्राउन एंड ब्रिज में अल्जीनेट से इंप्रेशन नहीं लिया जाता। तो ये सैड रियलिटी है। तो आपकी जो यंगर जनरेशन है, इस सैड रियलिटी को कन्वर्ट करो पॉजिटिव रियलिटी में, ताकि आगे जो लोग आए वो डेंटिस्ट को एज अ होप देखें। हम क्या करते हैं, जो नया इंटर का स्टूडेंट पूछता है डेंटिस्ट्री करे, हम लोग खुद कहते हैं कि तुम ना करो। अरे भाई, हम लोग डेंटिस्ट्री में रह के उनको डीमोटिवेट कर रहे हैं, गली गली कुछ में गालियां दे रहे हैं, तो हम खुद डीमोटिवेटेड है। तो मैं ये कहना चाहूंगा कि मोटिवेटेड रहो, इंस्पायर रहो, ताकि तुम लोगों के लिए इंस्पिरेशन बनो। और ये अपनी दुखी दास्तान, डिप्रेशन वाली कहानियां बंद कर दो, और कोशिश करो कि अपने आप के अंदर पॉजिटिव एनर्जी डालो, और इंशाल्लाह ज़रूर आप लोगों का वक्त आएगा। मेरी भी दुआएं। सॉरी थोड़ा लंबा हो गया। अच्छा, डॉक्टर सोहेब चीमा का सवाल है, मैम व्हाट पॉलिशिंग एंड फिनिशिंग प्रोटोकॉल फॉर कंपोजिट वी शुड इनकॉर्पोरेट इन आवर प्रैक्टिस।
देखिए, मैंने बहुत ट्रायल्स एंड एरर्स के बाद और बहुत सारे लोगों को फॉलो करने के बाद अपना एक प्रॉपर पॉलिशिंग प्रोटोकॉल बनाया है। फॉर इंटीरियर कॉम्पोजिट, आई ऑलवेज ट्राई टू यूज स्कल्पटिंग ब्रशेस विद वेटिंग रेजिन, ताकि मेरा पॉलिशिंग टाइम मिनिमाइज हो जाए। मेरी सरफेस इतनी रफ ही नहीं हो कि मुझे पॉलिशिंग पे टाइम स्पेंड करना पड़े, एक चीज़। दूसरी चीज़, आई यूज डिस्क। Initially, I used to use all grades of Softlex, but now I do not. I only use one coarse Softlex disc because जब आप उसको बहुत ज़्यादा यूज़ कर रहे होते हैं, it becomes fine. You're saving your money. You do not need to buy all four grades, right? Softlex के बाद use your rubber polishers at whatever, आपको अगर line angles बनाने हैं उस हिसाब से आप rubber polishers use करें. And then final, use a good diamond polishing paste, not the so called soul diamond polishing paste, the true diamond polishing paste with cotton buffs. जैसे मैं यूज़ करती हूँ लूसीडा, इट्स द बेस्ट सो फार। स्टाइल इटालियनो ने इंडोर्स किया है, उन्होंने मिलके बनाया है। सो आई यूज़ दैट। इससे पहले आई यूज़ टू यूज़ गोट हेयर ब्रशेस विद डायमंड पॉलिश, जो मार्केट में मिल रहे थे, अभी भी मिलती है, बट मुझे उससे वो रिजल्ट नहीं मिला। आई यूज़ टू यूज़ स्पाइरल व्हील्स, मुझे उससे भी वो फिनिशिंग टच नहीं मिला। सो आई एंडेड अप यूजिंग अ बेटर पॉलिशिंग सिस्टम फॉर कॉम्पोजिट, लूसीडा, सो मेरा ये प्रोटोकॉल है, डिस्किंग, rubber polishers, and then a good quality diamond polishing paste with felts, felt wheels हो या stars हो. This is my protocol.
ओके मैम, एक और सवाल डॉक्टर गुलाम अहमद अब्बासी पूछ रहे हैं, वी if we leave small carries behind, then it will fail or dislodge our restoration, but we are
It will be,
usually advised that we can leave soft carries behind. अगर pulp expose के chance हैं तो we can we leave question mark.
देखें इस पे मुख्तलिफ स्कूल ऑफ थॉट है. जो मिनिमल इंटरवेंशन की एक कैंपेन चल रही है, वो ये कहती है कि यू कैन लीव सॉफ्ट डीके on the pulpal floor if there is a chance of exposing and the tooth is asymptomatic. But आपका DEJ should be clean. Dentino enamel junction should be clean enough. So there should not be any decay in the periphery. There should not be any infected dentine in the periphery. और demineralized enamel नहीं छोड़नी है. तब आपकी बॉन्डिंग अच्छी होगी तो योर सॉफ्ट डीके विल नॉट पेनिट्रेट फर्दर, बिकॉज आपने बैक्टीरिया का सोर्स ऑफ फूड बंद कर दिया ना, तो इट विल डाई ऑन इट्स ओन. पल्प लाइनिंग के ऊपर भी अब दे नो मोर encourage the use of dicel. It's not indicated, and the best pulp lining material is a tooth itself. तो अगर आप दांत का वो हिस्सा, डेंटिन का हिस्सा ही छोड़ देते हैं, इट्स द बेस्ट पल्प कैपिंग एजेंट. यू डू नॉट नीड टू पल्प कैप इट. बहुत दिल चाह रहा है, यूज अ फ्लोएबल कॉम्पोजिट, या अगर पल्प एक्सपोज भी हो गए, यूज MTA. बट ट्राई टू नॉट लीव any infected dentine in the peripheral margin जहाँ पे आपका composite को seal होना है. This is what I advise.
डॉक्टर रफीउल्लाह खान पूछ रहे हैं कि हाउ टू डिसाइड वेदर अ कंटिन्यूइंग एजुकेशन कोर्स इज ऑथेंटिक और नॉट.
You have to do it first. पहले करना पड़ेगा और फिर उससे पता लगेगा. Actually the thing is, ये हो ही नहीं सकता कि आप बोले मैं किसी कंटिन्यूइंग एजुकेशन के कोर्स में गया और मैंने कुछ नहीं सीखा. अगर आप उस कोर्स में से एक छोटी सी बात सीख के निकल रहे हैं, इट सेव्स यू इन योर लाइफ लॉन्ग जर्नी, दैट मीन्स इट हैज प्लेड इट्स रोल. सो नेवर से दैट कि हम बहुत अल्लामा हैं और इस ये कंटिन्यूइंग एजुकेशन कोर्स ऑथेंटिक है कि नहीं है. You know, people who actually do that, they don't do it for the sake of money. Actually अगर उनको पैसे कमाने होते, वो पेशेंट से ज़्यादा अच्छे पैसे कमा सकते हैं, to be very honest. वो सारा टाइम दिन दे के, they don't earn a lot in those courses. वो अपना अगर टाइम निकाल कर अपनी फैमिली को वीकेंड्स पे छोड़कर आ रहे हैं, तो वो पैसे कमाने नहीं आ रहे, वो आपको सिखाने आ रहे हैं. तो डोंट से दे आर ऑथेंटिक और नॉट ऑथेंटिक. You will actually learn something, if not 100%, but something. उसके लिए आपको उसमें इन्वॉल्व होना पड़ेगा. एंड ऑलवेज यू कैन ऑलवेज आस्क द ऑर्गेनाइजर्स कि आपके लर्निंग ऑब्जेक्टिव्स क्या हैं, व्हाट आई विल एंड अप लर्निंग. सो यू कैन सिलेक्ट दिस वे, राइट.
परफेक्टली सेड. मेरे ख्याल में ये सवाल एंड हो चुके हैं. अगर किसी को बाद में भी कोई सवालात हों तो आप ग्रुप में पूछ सकते हैं आप लोग. और आई थिंक वी शुड एंड. थैंक यू सो मच डॉक्टर नजिया फॉर द वर्दी टाइम, और इट वाज अ वंडरफुल सेशन.
आपका
थैंक यू
भी
सो मच.
शुक्रिया. थैंक यू सो मच. आई होप आई डिड कंट्रीब्यूट टू सम लर्निंग. थैंक
नो,
यू.
ओके, जज़ाकल्लाह, जज़ाकल्लाह. अस्सलाम वालेकुम.